Okay, Praveen, it's 12:30. If you want to go ahead and get started, I'll just take a moment or so to just say what I have to say. So
Sure. Yeah.
let's move forward.
Yeah. No, thank you all for joining us. This is Praveen Manam from Labar Pulmonary, and we are honored to host this Meet the Professor seminar with Dr. Steve Nathan, and we are hosting this with the North Carolina Thoracic Society. We're excited to hear from Dr. Nathan about post-COVID interstitial lung abnormalities. As we're digging out of the COVID pandemic, this is an emerging problem. And anecdotally, and by preliminary reports at least, we're struck by how much this affects patients, even patients who have mild disease. And there's really not much literature out there. So we're glad that Dr. Nathan is going to talk to us a little bit more about that. Dr. Nathan is a medical director at the Advanced Lung Disease and Transplant Program at Inova and a professor at University of Virginia. He's has over 400 publications, mostly in interstitial lung disease, and he's one of the foremost experts in the world in interstitial lung disease. So we're glad to have him here. And before we move on to our talk, I'm going to have Dr. Roy Pleasance, the Executive Director of the North Carolina Thoracic Society, give a few words. And
Hi.
before we move on, all of you are
Praveen.
on mute. And if you have any questions, we plan to have at least 10 minutes of questions at the end. There's a chat function. If you want to put your questions in there or text me if you have my cell phone, then I can moderate the questions at the end. So take it away, Roy.
Okay. Well, thank you, Praveen and Dr. Nathan. Really, it's an honor to have a world-class presentation on an incredibly important topic that many practitioners, particularly pulmonologists, are dealing with. But this is part of our Meet the Professors series. Unfortunately, we put it on hold like a lot of other things. But really, our goal is to work with different practitioners, whether it's one practitioner in a small town in North Carolina or a health system like Cone Health, to bring experts to them, ideally in person, but, certainly virtually work. So this is part of that. And then also, of course, I want to put in a plug for our September annual meeting in Asheville. That's going to be another world-class program, including Patricia Rivera, who's the, I believe, upcoming or is now the vice president of ATS, talking about the new lung cancer screening guidelines, and really a fantastic program that James Davidson, our president from Asheville, put together. So in any event, thank you, everyone. And if you want us to reach out to you and offer a Meet the Professor, even if it's just a dinner with two people there, wherever you are, we're more than happy to try to pursue that. So I'll turn that over to Dr. Nathan and thank him for his very valuable time and insight.
I'd like to thank you very much, especially Praveen, for giving me the opportunity and inviting me. And who would have thought 18 months ago I'd be giving a talk on this topic? And we've all had to become emergent COVIDologists and Zoomologists at the same time over the last about 18 months. So I enjoyed putting this talk together because it's a talk I hadn't given before, and I struggled even with the start, with the title. What should I call this talk? But there you see the title right before you. Let's see if I can move my slides. There we go. I'm moving them. All right, there's the little bug we're talking about. So these are my objectives. I'll try and cover some of these things. I will go a little bit tangential at times, so let me forewarn you about that. We'll talk about the role of advanced lung disease, ILD docs in the pandemic, cover some radiographic changes, talk about whether COVID-19 causes or contributes to interstitial lung disease, talk about interstitial lung disease, how they might be affected, and we'll also cover antifibrotic therapy a little bit, and also lung transplantation just a little towards the end. So what just happened? 2020, what a year. And when this started in March, I remember someone said to me, well, Steve, what can we expect? And I said, well, it's like going down the rapids. You can see what's ahead of you, and you're in this boat. It's like class 5 or class 6 rapids. There's cliffs on either side of you. You can't get out of the boat, and you just got to hope that you hold on. There will be an end in sight, and you just hope that you're in the boat when you come through the rapids. And I think we've all kind of experienced that in one way, shape, or form. And we've all gone at various times WTF, but that's not what it stands for. The lesson emerging from the rapids, obviously, one of the lessons is wear the face mask. And we're just starting to peel those off now as the vaccines are starting to take effect. So, and if we go back to March, we are under an avalanche, not only of patients, but also of papers in the literature. There were all these papers coming out, and it was very difficult to keep up with emerging literature. I did a query just today. I did a PubMed search. I put in COVID-19, and you can see the number of hits that there were from 2019, 2020. And as of today, just under 165,000 publications with COVID-19 mentioned in them. When I did that search and I did COVID-19 and ILD, I narrowed it down to just over 7,000. Tried to narrow it down further, but it made it more papers. COVID-19 and pulmonary fibrosis, over 7,500 papers. So I can tell you I didn't read that many, and so it's very hard to keep up with the literature, and there might have been some things certainly that I missed along the way. So at the outset, I think this kind of summarizes all of us what to do. We didn't know what to do. We were under this avalanche of patients and papers at the same time, and there was this drug, try me, no, I'm the cure, and we were all kind of like deer in the headlights through all of this. If you look at all the treatments that have been touted and some trialed, it's been a bit of a zoo. This is just some of them that have been out there that there is some literature on or people have spoken about. And it's no wonder that we've all kind of been deer in the headlights as we've tried to muddle our way and come up with therapies that we could offer our patients. So what about us over here in Northern Virginia? We're in the Washington, D.C. suburbs. You can see our hospital there, Inova Fairfax Hospital. We're right on the Beltway with downtown D.C. about 20, 25 miles away from us. And over here is the NIH in Bethesda. I'll talk a little bit about the NIH because we have very close ties with the NIH and have done a lot of COVID research over the last about year with the NIH, some of which I'll be talking about. And our hospital is a 5-hospital system. The other hospitals are shown with the red triangles, and that's a nice picture of the South Patient Tower of our hospital campus. So we had our first patient admitted on March the 6th of last year, and on March the 15th, the hospital system asked me to help lead the research into COVID-19. And I felt like we, as an advanced lung disease ILD doctor, 8 clinical research coordinators, 7 other docs together with me, we were perfectly positioned. It's not something we wanted, but we were well positioned to undertake this. So we made some t-shirts, everyone rolled up their sleeves, and we got busy not only taking care of patients, but also doing COVID-related research. These are the studies that we did that we were engaged in: remdesivir. We had a convalescent plasma program, sarilumab, nitric oxide, ATIA, and you can see the rest of them. The one that I'm going to talk about that we did with the NIH, which was a phase 2 safety study, is this study at the bottom, fostamatinib, and I'll try and tie that into interstitial lung disease as well. This is the COVID tracker. As of yesterday, 33 million cases in the US, 597,000 deaths. I thought it was over 600,000. And then you can see that I Googled this. I went to the site again today, and there's been a bit of a change. So it's not mission accomplished yet. We still have cases. We'll still be admitting these patients for a while. And this is what we've seen in the US in terms of cases. And I know that it's going down in your area as well, because I did hone it down to North Carolina. You can see the numbers there that I'm sure you have all experienced. And in comparison to Virginia, it looks like we have more cases, but the scale is different. Here, 6,000 we peaked at, and you guys peaked out, it looks like close to around 10,000. So we've all been affected by this. What's interesting is that most of the cases have been towards December, January, February, but most of our hospitalizations were more towards March, April, May of last year. So it just tells us something about that we're doing a better job perhaps at picking it up earlier, and maybe with outpatient treatments, and certainly the vaccination rate is impacting the need for hospitalization. At Inova Fairfax, we've had over 4,000 COVID admissions, over 800 ICU admissions, and about 60 ECMO runs for COVID. We've all seen this. This is a CT of a patient with diffuse ground glass infiltrates. This was a patient with COVID. And the first inklings of how it might manifest radiographically and if it could cause interstitial lung disease came out of China, where the pandemic originated. And so what we see from some of these early studies is the mention of interlobular septal thickening. Is that some kind of ILD on its way to ILD? And from this particular series, they reported fibrosis, at least radiographically, in about half the cases. This is from another series, also out of China, looking at the evolution based on serial CAT scans. And you can see that there's a mention of reticulation, and reticulation appears to be emerging even as early as 2 to 3 weeks after the initial CAT scan. So we start to get an inkling here that maybe we're going to have an emerging problem of COVID-related interstitial lung disease. This is from another series looking at changes that could be emerging ILD, interlobular septal thickening, 49% at the first CT after discharge, going down to 35%, but persisting. Subpleural lines, 21%, 7 or 8%. Irregular lines shown over there. Bronchiectasis, mostly traction bronchiectasis or bronchiectasis, does occur and tends to persist in some patients. This is from a systematic review of over 4,000 patients, a couple of studies. And what do we see here? Subpleural lines, 25%, pulmonary fibrosis, 17%, bronchiectasis, typically accompanying pulmonary fibrosis, 18%. So can COVID-19 cause interstitial lung disease? I think the evidence is clearly there. But as I was putting this talk together, it made me think about interstitial lung disease in general. First of all, we have our little bad boy over there. Hell yeah, I can do whatever I want. But then I started to think, what is interstitial lung disease, by the way? We do it every day. And I'll show you, we'll take a step back and talk about interstitial lung disease in general, and then how COVID might fit in that. So I actually came up with a definition. This is from the ALA. Interstitial lung disease is an umbrella term used for a large group of diseases that cause a scarring of the lungs. I think that certainly inflammation can be part of it as well. But here we have our organizational chart of how we like to think about interstitial lung disease, all the big groups. Most of them defined initially pathologically. So which of the pathologies might we see with COVID? Certainly non-specific interstitial pneumonia, acute lung injury, ARP, COP has been well described, pulmonary fibrosis has been described, although we couldn't call it idiopathic in the context of COVID. And then a big umbrella wastebasket term is unclassifiable. So where would we put COVID-related interstitial lung disease under all of this? It's not idiopathic, it's not granulomatous, it's not other. So it probably belongs over there. Known cause or association, right under there, together with the CTDs and occupational lung diseases. Let's talk about our HRCT ILD patterns. And based on the guidelines, we divided into UIP pattern. This is a typical UIP pattern, subpleural honeycombing, no atypical features. So that's our UIP pattern. This is a probable UIP pattern. You can see diffuse fibrotic changes and traction bronchiectasis. We have our indeterminate scan, which is subpleural reticulation, amongst many other things that can give you an indeterminate scan. And then lastly, alternate diagnosis suggested, alveolar infiltrates, more central location of these infiltrates. And so that's how we categorize our ILD patients on the way to ruling in or ruling out IPF. So how do we as a group do with this? And this is where I digress a little bit because this is an interesting study that our group undertook and was published earlier this year. As you know, there's not great agreement amongst expert ILD docs and even thoracic radiologists. So we did this study, and this looks like a heat map, a gene heat map. I get jealous when I read the literature and I see our colleagues who work in labs come up with these very nice pictures and diagrams of heat maps. So this is a radiographic heat map, and I'll explain what we did here. Each of these 50 rows represents one patient, and we had 6 readers, including 1 thoracic radiologist, 5 pulmonologists, all of whom do ILD. They were given the same cases, blinded to any clinical information, blinded to their colleagues, and they had to categorize them as UIP, probable, indeterminate, or alternate diagnosis suggested. And you can see that it's a little bit all over the place. This would represent a case of concordance all the way through, but there's actually even one case over here where all 4 patterns were distinguished by our experts. UIP all the way through to alternate diagnosis suggested. So it's all very well and good when we come up with great examples of what UIP or probable should be, but realistically in the trenches, that's not how these cases present, and there can be a lot of confusion or misclassification perhaps amongst ourselves as we look at these cases. So I thought that would be an interesting aside to share with you guys. What about pathologic patterns? What are the pathologic features of interstitial lung disease? And I borrowed this slide from a colleague of mine, Kevin Leslie, who used to be a renowned pathologist at the Mayo Clinic. And what Dr. Leslie has done is divided pathology into 6 patterns. Over here, we have acute lung injury, DAD. Next one is fibrosis or a UIP pattern shown over here. The third pattern are cellular infiltrates, the prototypical illness being NSIP or cellular NSIP, a good example of that. The fourth pattern is an alveolar filling process or organizing pneumonia, cryptogenic organizing pneumonia, and you can see a lot of organizing pneumonia within the alveoli here. The fifth pattern would be nodules. Prototypical illness is sarcoid. And the last pattern is small airways disease. So which of these pathologic patterns might we see with COVID? You can certainly see DAD, probably UIP, NSIP type pattern, and organizing pneumonia has well been described in COVID. So already we know that COVID can give these various forms of interstitial lung disease. Mechanistically, how does this come about? And there are probably many things in play in terms of the pathogenesis of ILD. And we'll start off at the top. Mechanical forces, we know that shear stress, volume trauma, all of these things can be injurious and result in diffuse alveolar damage and possibly leading on to fibrosis. When we started out in the pandemic, patients were intubated. The big thing was, let's get ventilators. Everyone was put on a ventilator. And then we said, let's put the brakes on that, and let's not put these patients on mechanical ventilation if we can avoid it. But even patients breathing spontaneously can generate very high negative intrathoracic pressures, and that shear stress can actually has been shown to stimulate fibroblasts. Aberrant repair, we'll talk more about pro-inflammatory cytokines in a minute. Oxygen, both hyperoxia we know can be damaging to the lungs, as well as hypoxia can be damaging to the lungs. ARDS sometimes can give a little bit of residual fibrosis, the effects of the virus itself. And then thromboembolism, we know these patients certainly are at heightened risk of thromboembolic events, but there is a link perhaps between that and the genesis of interstitial lung disease. So let's dig a little bit deeper into some of these pro-inflammatory cytokines. And I have listed here a bunch of them that have been shown to be upregulated in COVID-related disease. IL-6, we know we have targeted therapies for that through tocilizumab and others. But the one that I want to focus on is this one over here, NETs. Let's talk a little bit about NETs and what are NETs. So nothing but NETs, not the net you're thinking about, not the Brooklyn Nets either. But what this stands for is neutrophil extracellular traps. What are NETs? That's what they look like under EM scanning. This is a neutrophil, and it looks like a net. This is what happens when the neutrophils undergo programmed cell death, and they release chromatin as well as other products that were typically intracellular. And this is a cartoon depiction of what happens with net formation or netosis. So we know that neutrophil attractant proteins are upregulated in COVID-19. We know that we look at lymphopenia as a biomarker of disease severity in COVID, but what's missed sometimes is neutrophilia, and that's also been associated with severity of disease. So we have a neutrophilia in COVID-19. What has been shown is that SARS-CoV-2 can induce net formation in healthy neutrophils, And NETs can be damaging. They can lead to multiple different things. Endothelial dysfunction that we see in COVID, they can lead to microvascular thrombi, and increased NET production has been shown not only in COVID-related disease, but in many forms of lung disease, some of them shown over here, including IPF, by the way, as well. So this was a proof of concept lab study that was undertaken by some of my colleagues at the NIH. I've since worked very closely with both Jeff Stritch and Rick Childs, who heads up the clinical center at the NIH. And what they did is they took a drug, as we're looking at repurposing different drugs. Fostamatinib was one of the ones that was looked at. This is a drug that's approved for idiopathic thrombocytopenic purpura, RTP. And they took the plasma of patients with COVID-19, and you can see they stained them for NETs. These are markers, immunofluorescence for NETs. And then they applied this metabolite. This is the main active metabolite of fostamatinib, R406. This is COVID-19 plasma without R406. This is plasma with R406. So this was proof of concept, and the NIH approached us then to do a 2-center study looking at the safety and tolerability of fostamatinib in patients with COVID-19. And I'll share some of those results with you in a minute. So this was when the study was closed. We recruited mostly over the winter. 2-center study. We got 58 patients in between the 2 centers. Most of them came from our institution. I think we had 42 or 43 of the 58 patients. And the results, there was a press release, so I can share it with you. All of this is public information. Press release was in April. So what was that? May, June, 2 months ago. And this is what we showed. Remember, we set out small study, a true randomized control study, double-blinded, and it was mostly looking at safety and tolerability, but obviously hoping for a signal as well. We showed, first of all, that fostamatinib reduced serious adverse events by half, so that was a good start. And then as we dug a little bit deeper, there were 3 deaths during the study. All of them were in the placebo arm, none in the fostamatinib arm. And there were 4 intubated patients, 2 in each arm, 2 on fosta, 2 on placebo. The 2 patients on fostamatinib survived. The 2 patients in the placebo arm succumbed. So there was a small signal on the bad end of the disease, but there was also a signal on the good end of disease in terms of time to improvement, where it appeared that those patients who received fostamatinib therapy did better quicker and got out of the hospital sooner. And ICU length of stay was also reduced. Interestingly, all the patients were on standard therapy with both steroids and remdesivir. So this was on top of standard of care. So certainly a safe intervention, and the suggestion perhaps of some efficacy, and there's a phase 3 study that's ongoing at the moment, recruiting at this time mostly in South America. So more to follow. We've certainly been fooled by many phase 2 studies before that haven't panned out in phase 3, but quite promising, and also accompanied by some biomarker changes that move directionally in favor of fostamatinib. More to follow. But why do I show this? Because we're always looking for that silver lining. What's the silver lining of COVID-19? Maybe it will lead to discovery that might affect other areas of medicine, including ILD. So here is something about net formation and how nets can affect fibroblasts. And there was another paper looking at net formation in ILD due to polymyositis. So this is a bit speculative, and hope against hope on my part that maybe some of the therapies that we try in COVID will have a ripple effect and find utility in other diseases that we all deal with. Does COVID-19 cause or uncover ILD? There is this entity here of interstitial lung abnormalities, and this is a relatively newly described entity. This is one paper from JAMA published 5 years ago looking at patients with early interstitial lung abnormalities versus those without, showing that if patients had interstitial lung abnormalities, their mortality over time was significantly worse. And these were big series, 1,300, 3,200, 1,000, over 600 or 700 patients here. What is interesting, and why I show this, is because between all these different cohorts, these 4 different cohorts, the prevalence of interstitial lung abnormalities was between 7 and 9%. So think about that. We've had 33 million cases of COVID in the US. 7 to 9% of the population, albeit these were more elderly patients, have interstitial lung disease. So it makes sense that maybe developing COVID just uncovers interstitial lung abnormalities that were pre-existing that hadn't as yet come to clinical attention. This is one such example of a patient that I saw in March of last year. He was admitted at a time where our testing wasn't very good, but he lost his smell and he lost his taste. And this was his CT. But what appeared to me was he did have these more alveolar or consolidative areas, but there did appear to be pre-existing interstitial lung disease already before he developed COVID. How do patients with pre-existing ILD do once or if they develop COVID-related infection? There have been at least 2 studies out of those 7,000, most of which I didn't even look at. And this is one such study that was published in the Blue Journal towards the end of last year. And 46 ILD patients. This was out of the Brigham and Mass Gen system. I think they have 6 hospitals. And they looked at the ILD patients who were admitted with COVID and propensity matched them to 92 patients without COVID, or without ILD rather. And this is what they saw. More of them were on immunosuppressive therapy, and the mortality was significantly higher. 33% of them succumbed versus 13% in the control group that was matched for other factors, including comorbidities. So 4-fold increased risk of death, more likely to be hospitalized, and more likely to require ICU. Another study, this is an international study out of Europe, showing pretty much the same things. Poorer survival, mortality was way up there as well, 49%, hazard ratio higher, and they identified 2 things that were particularly associated with worse outcomes. A baseline FVC of less than 80% and obesity. Kind of makes sense. And the mortality was significantly higher in that population as well. I'll go through 2 of the cases we've had at our own institution. This is a patient with pre-existing ILD. You can see that the date of the CT was from March 2019. This is a patient with anti-synthetase syndrome, March 2019, before we had all of this. And once the patient developed COVID, this is how the CT evolved. This is August 2020. Once again, at lower cuts, August 2020, you can see these diffuse parenchymal changes on top of the baseline ILD. And this is from April 2021. A lot of this looking fibrotic. You see traction bronchiectasis here. And this was actually a patient we just recently transplanted. We'll talk more about transplant in a minute. So can COVID cause pulmonary fibrosis? And this is one early case series, was published in the Korean Journal of Radiology, looking at CT over time. Over here, you can see how these alveolar infiltrates evolve. And here we have some cystic changes, maybe a little bit big for honeycombing, but certainly looks more fibrotic now. This was only 1 week after the onset of symptoms, and this was day 19. So the virus moves very quickly, and it seems to move very quickly as well in terms of the propensity to cause significant interstitial lung disease. Another case report, this is out of France, rapid onset honeycombing. Here we see more apical cuts. You can see alveolar infiltrates there on the right. And this is distinct honeycombing now, replacing those initial alveolar infiltrates. Working our way down towards the basis, we see further honeycomb change. And right at the basis here, this looks like a UIP pattern that's evolved in what space of time? Well, if we put a time scale there and we call this CT day 0, who would guess this looks like something that could take weeks to months to develop? But this was day 10. So a very rapid evolution, as they said in the titling. A couple of post-mortem series. This is out of northern Italy. I put this here because these were patients who had relatively early mortality. They were in the hospital they were in the ICU rather for 1 to 23 days, mean of 7 days. And you can see the evolution over here from diffuse alveolar damage with hyaline membranes all the way through to maybe the suggestion of some early fibrosis and inflammatory changes. Probably if you looked at something like this, panel F, without knowing, you'd call it a mixed cellular fibrotic NSIP type pattern. But this is what they described in a total of 38 patients, all of whom came to autopsy. Let's see if there's evidence of fibrosis. Yes, there was, 37%. Microscopic honeycombing, 61% in 38 patients. So certainly this is evidence of fibrotic disease. If you think about all the patients who have succumbed to COVID, about 600,000 in the US, if all of them had to be subjected to autopsy, one would think that they would all show very similar changes. So certainly COVID can cause significant ILD and significant changes, including honeycomb change, if hypothetically we were to perform autopsy series on all these patients. This is another case. What we see over here is the base is the CT early on, panels A and B, and the CT C, D, E, and F are taken about 2 months later. This patient succumbed and went to autopsy, and now we're seeing diffuse alveolar damage. But now, 2 months later, we're also seeing microscopic honeycombing. Another case of ours, call it case number 1, typical changes, diffuse alveolar infiltrates, maybe a little bit of crazy paving going on. And this was in late April of last year. And this is how the patient evolved. This is June of 2020. You can see the extensive fibrotic changes with extensive traction bronchiectasis towards the bases as well. There's case number 2, kind of much of the same, patient intubated at this point, and changes all the way through, including what looks like fibrosis. Although I will say, a lot of times we see what appears to be fibrotic changes, and sometimes, or many times, those patients tend to improve. And it's very hard to distinguish who's going to do what. That's one of the big challenges. Same patient, early July. Looks like a lot of fibrosis. Yeah, and you can see extensive traction bronchiectasis. I'm sure everyone's seen many examples of CAT scans like this. But not everyone does that. Certainly the patients who never make it out of the hospital, if we had to CT all of them, would see changes that are very similar. What about folks who are discharged from the hospital post-COVID? Thankfully, most folks will end up having pretty normal lung function. Even those who had severe pneumonia, can see this PFT series, most of them return to normal lung function. So that's reassuring. Is there a role for antifibrotics in COVID ILD? And that is the $64 million question that remains to be answered. Let's have a look. This is taken from a paper out of China in the early stages of the pandemic, looking at some of the cytokines that are upregulated. And I show this for one reason. You'll recognize these 3 different cytokines: fibroblast growth factor, platelet-derived growth factor, and VEGF. These are the cytokines in particular that nintedanib affects. Nintedanib, as everyone knows, is one of our 2 approved antifibrotic therapies. It's a TKI. So this does raise the notion of, well, gosh, maybe nintedanib could have some effects in terms of ameliorating the disease. Speculative, we don't know. Just because it affects these different cytokines doesn't mean that it will. We've seen mixed data between sarilumab and tocilizumab targeting IL-6. So sometimes things that appear to make biologic sense don't pan out in clinical practice. What about pirfenidone? Pirfenidone's a true pleiotropic molecule that has multiple different effects. This was a very nice review in the Red Journal published last year about the effects of pirfenidone. I'm not going to go through all these different pathways, but I will highlight some of the cytokines that have been shown to be upregulated with COVID-19. So same concept, could pirfenidone have effects for the disease itself? This is an older paper from H1N1, and are there lessons to be learned? There were 3 patients who had H1N1 and perhaps share some common ground with COVID-19. These patients were treated with pirfenidone and appeared to improve. Now, this might also be a case of true unrelated. Sometimes we put patients on therapy and the patients might have been predestined to get better by themselves, but then we attribute their improvement to the therapy that we chose to put them on. And this is the difficulty as well. We really need randomized controlled studies to know if there's a role and in whom there is a role for antifibrotic therapies, because many of these patients will go on to natural resolution, albeit it can take sometimes weeks to months. What about persistent post-COVID interstitial lung disease? This was a British series published quite recently in the Annals ATS, in fact, just last month. Let's go through these numbers, which are difficult to see. There were over 1,200 patients diagnosed with SARS-CoV-2 who were discharged. 837 were assessed by telephone 4 weeks after discharge for residual symptoms. Eventually, as we worked our way down this tree, 77 of these patients were evaluated through a multidisciplinary team discussion. 59 patients were found to have post-COVID CT changes, and 35 patients with post-COVID ILD that warranted treatment out of all of this. So what's the prevalence coming out of the hospital after having an episode of COVID? Now, remember, these aren't patients in the hospital. These are patients who are discharged. So if we look at what are we going to use as our numerator and our denominator, we have as potential denominators here 1272 or 837. Using both of these numbers, using the 77 patients evaluated at the MDD, anywhere from 6 to 9%. Using the same denominators, but looking at these 59 patients with post-COVID CT changes, now we're at 4% to 7%. And these patients with what sounds like real significant ILD, 35, either between 2.8 to 4.2%. If you think about the universe of patients who've been admitted to hospitals, of those 33 million, there have been over 2 million admitted to US hospitals. This is going to be a real issue, and we're seeing the results of that already. These patients, many of whom had COP, and I think that's an important concept, were treated with steroids and improved sometimes weeks to months after their initial infection. So when we see these patients, even if they might have been treated with Decadron or other steroids early on, we'll always retreat them and sometimes give them a pulse or Solumedrol to see if we can get residual improvement. This is from the same series showing such a case. Panels A and B are what appear to what the patient had. Patient was treated with high-dose steroids, and there was resolution. So I think we should never miss an opportunity to treat patients with steroids in case they might be responsive even weeks to months after their initial insult. So just a couple of other papers I came across as I was getting this all together that I wanted to share with you. Observational study of follow-up CTs in 81 survivors. More than half had radiographic evidence of pulmonary fibrosis. 44% discharged after COVID-19 treatment. Lung function abnormalities, 47% and 25%. Autopsies, another autopsy series of 30 patients who died from COVID-19, 43% had some evidence of fibrosis. What about lung transplantation after COVID-19? This is the various phases that we see with COVID infection, resolution, and residual lung damage. Once again, we don't know who's going to have residual lung damage and who's going to go on to have natural resolution. And I think that's a problem we're all grappling with at the moment. How do we manage them? No mechanical support, some mechanical support, and occasionally ECMO support. The transplant sweet spot, how do we decide that? And this is something we struggle with. We just submitted a paper to CHESS, which was between a bunch of different programs talking about this very issue. So hopefully that will be favorably reviewed. We don't want to do patients too early because they might recover. And we don't want to wait too late because they could be too debilitated with poor rehab potential and at that point have multiple comorbidities. So what has been the story of lung transplantation in the US? You can go to the SRTR data to this website. The address is the OPTN website rather, and you can actually do the search. I've done the search a couple of times to see how many COVID-related transplants there are in the US. And here's the answer. 2019, no surprise, N equals 0. 2020, N equals 21 transplants in the US. Where are we today? And this, as I was saying earlier, I was putting this talk together as early as 40 minutes ago. And this was the last search I did. Where are we today? Total thus far today, 102. You can see how that number is growing and will continue to grow. In fact, we did our believe it was our 4th COVID transplant just this morning. So this number is going to grow. We're all seeing these patients now as we come through the tail end of the pandemic. This is the search as you showed it. There's 2 codes for it, COVID-related ARDS or COVID-related pulmonary fibrosis. So certainly it's a short-term cause of interstitial lung disease, but is it also a long-term risk factor for interstitial lung disease? Let's talk about that a little bit. Will we see more ILD related to COVID, not for the immediate, but 1 to 5 years down the road? We've shown that post-COVID ILD does belong in the circle of ILDs, but is it cause or contributory? And we've spoken about cause, and now we'll try and address contributory. If one looks at the risk factors for IPF, these are the various risk factors, including environmental and occupational. I'm not going to go through each of these. I can summarize them with one word shown over here. Crap. The more crap you breathe into your lungs, the more likely it is you're going to develop IPF. This is not what you're thinking. This stands for circulating respiratory airborne particles. Now, is COVID going to be part of the crap that people have breathed in previously that's going to lay the foundation for the subsequent development of IPF? IPF is a true epigenetic disease, something in patients' genes, something in the epidemiologic environment that they've been exposed through the years. It might not just be one thing, it could be multiple things layering on top of one another. And then the third in the triad is age. It's a disease of the aging. So I think as we see patients with ILD, we're going to have to ask them about their prior exposures to include prior history of COVID-19. By way of example, we've seen delayed onset of lung disease in our veterans returning from Iraq and Afghanistan, sometimes years later. So will we see the same with COVID-19? We know that viruses have been associated with IPF. I'm not going to read all of this. EBV, CMV, adenovirus, all have been found to have an association with IPF. So will the same hold true for COVID-19. To summarize the slide, IPF viruses, is there a link? There's a link. There does appear to be a link. So coming towards the end of my talk, it's been quite a journey. The journey is not over yet, but we're in a very different place today from where we were in March of 2020, when we were deer in the headlights, throwing the kitchen sink at this disease, going through all these different things, waiting for the vaccine. And now where are we today in June 2021? Vaccines, got to continue that fight, get everyone vaccinated. We're talking about vaccine boosters. We'll discover more drugs to treat, hopefully, more testing, certainly, more back to normal. We're seeing that already. And more long haulers, including patients with interstitial lung disease, no doubt. So from deer in the headlights to a happier place, and I'll stop right there and be happy to take any questions. Thank you all very much.
Thanks a lot, Dr. Nathan. That's a great talk, very comprehensive on a difficult topic. So as a reminder to others, we're recording this and hopefully we'll have this up on the North Carolina Thoracic Society soon. Please type your questions into the chat box and I can go through them. Now, one question that we have was, you've shown very nicely that COVID may increase fibrotic pathways, right? The VEGF and so on. Is that a precedent for this? Do you think, is it a part of, is it unique to COVID, maybe related to other coronavirus or just any other viruses in general can do this? Because it seems to be a more fibrotic, you've shown us very nicely that it seems to be a more accelerated fibrotic pathogenesis.
That's a good question. I think that's one of the unknown things that it's difficult to answer. There does appear to be an association between viral infections and fibrotic lung disease. I think certainly much more accentuated with COVID-19. Will we see this with other viruses? I've always felt like the viral link to IPF has been very soft, but this maybe is time to rethink that there are certain viruses that might truly increase one's predisposition to developing pulmonary fibrosis. There are many questions that are yet to be answered. That would be another one of them.
Right.
I have a feeling I'll be saying that with many of the questions you guys might have.
That's right, a lot of unknowns here. Next question from Dr. Krim. In these cases presented from last year with CTs, are there any follow-up CT in 1 year? And I'll just add on to that. You've shown that many of these cases have macroscopic honeycombing, right? So there's a concept now that once you reach a honeycombing stage, it can be a self-perpetuating cycle of pulmonary fibrosis. Have you had any follow-up for a year? Have you seen any progression of this fibrosis?
Unfortunately, those patients that I showed either succumbed or got transplanted. So some of the ones I showed, it's very hard to imagine that there's going to be resolution. I think one of the things that we really need a biomarker for, or better knowledge, or some kind of radiographic phenotyping, are those patients who are predestined to go on to develop end-stage fibrosis from which there's no recovery, versus those who might have more COP, where there can be an opportunity for resolution over time. But I don't know, that's kind of one of the magic bullets that's out there. We struggle with when we get sent these transplant referrals. Sometimes it seems pretty clear-cut, and other times we're kind of scratching our head and say, maybe we need to give it more time. What's actually an interesting concept to me with regards to transplantation is, there's a greater trend to do more bilaterals than singles, but for some of our patients, we'll take anything. If they're in dire need, we'll give them a single. And you do wonder if that might give one the opportunity to follow the natural history of these patients with seemingly very advanced fibrosis. And we've seen cases like this before, where a single lung transplant might be a bridge to recovery of the native side that's left behind. So I think that's something that we'll learn about. I suspect most of these patients are getting bilaterals, but for those patients who are getting singles, will there be resolution 6 months later, 1 year later? That I think is going to be a very interesting question.
Right. We have been following some of these patients, and I think the earliest follow-up we have is 6 months. And if there is an inflammatory change like organizing pneumonia, that certainly gets better. Ground glass gets better. But once you have traction bronchiectasis and what we feel is more end-stage fibrosis, we haven't seen any change. It seems to be stable so far, but it remains to be seen down the line.
I think, we might have had one case that I remember anecdotally that there did appear to be some traction and they did improve. But I think there is probably that inflection point where you look at it as like, there's no way this person's going to get better. They 2 months out or 3 months out and they still, on ECMO or, requiring high flow. So I think we're doing as best we can, trying to figure out who those patients are. But I'll go back to what I said. I think everyone warrants another course of steroids beyond the initial decadron, just to see maybe there is some COP or something else going on that could be reversible.
That's great. It just leads on to our next question from one of our viewers. How late have you seen the response from steroids with COVID-19 changes?
I'd say sometimes 2 to 3 months, you can still see some response. Probably it makes intuitive sense that the longer they go out, the less likely it is that you're going to see a response. Yeah.
Now, from that paper that you showed us, I think they used from England, right? I think they used a lower dose of steroids.
I think you're right. It wasn't a huge dose. I don't know why 30 milligrams of prednisone sticking in my head, but they didn't. I don't recall them pulsing them. It wasn't a huge dose of prednisone.
Right. So if you're thinking organizing pneumonia, I guess my thoughts are like 1 milligram per kilogram over a few months, or what is the dose that you typically use for these patients?
I think that's reasonable. I think this is not cookbook, but what I would say, if a patient is languishing in the hospital, because we've had a number of transfers to our place, considered transplant, we'll pulse them. We'll give them like 500 milligrams IV daily for 3 days, like we would an episode of acute rejection. Because in those situations, you want to get an idea if there's any reversibility as soon as possible, rather than, okay, we're going to put you on 30, 40 of prednisone and we'll bring you back in 4 to 6 weeks and see how you're doing. So I think you have to tailor it case by case.
Right. One other question here from Roy, it seems like it'll take a long time to determine if antifibrotics work. What should the clinicians do now? That's a tough one.
That is a tough one that we all struggle with. And we are guilty here of putting some patients on antifibrotic therapy. When you're in the trenches, you do what you feel is best for those patients. We've had a problem getting it paid for outside the hospital for some patients and others not. I think that we need the randomized controlled studies to see. We don't, we don't know what the natural history of this is in all comers, so we do need a true placebo arm. Even that very small series I showed you from H1N1, the 3 patients got better, but who knows? It might also, once again, be true, unrelated. Will we see a true randomized controlled study? I'm not sure. Given that when you're in the trenches and you're faced with an individual patient, I think you have to do what you feel is best for that patient, and sometimes that is trying them on an antifibrotic, although there's no good literature to support it, and it's purely maybe speculative on my part, but we all do that. It's much like at the start of the pandemic where we were throwing all these different drugs at the patients. We couldn't wait for randomized control studies. And if you think about, well, gosh, the downside is the patient's going to be a respiratory cripple, or they might have, I might have to send them for a transplant. I don't think it's unreasonable to try an antifibrotic just to see if you can get some resolution. I'm talking very much off-label. This is case by case. You have to use your judgment. I don't want to endorse and say, well, give antifibrotics for all these patients post-COVID. I think you have to use your judgment on a case-by-case basis. But the point I'm trying to make is, much like we've seen with the pandemic, the virus moves very quickly. The sequelae evolve very quickly. And sometimes we just can't wait for those RCTs to come to fruition.
Right. I guess I'll add to that, just look for other causes or other comorbidities and treat them, like COPD, OSA, asthma. And we've been sending patients to pulmonary rehab too, and that's helped them tremendously. Treat them like any other ILD, oxygen therapy, pulmonary rehab, weight loss, and so on.
Absolutely, I agree. And you're right, like any other ILD, you focus on all these other things as well. I need to say I'm not endorsing antifibrotics for post-COVID, but I'm saying that you have to use your judgment on a case-by-case basis.
All right. Can I ask you a question about the transplant? You said there's a paper or a manuscript out for review. Or could you just tell us what is your sweet spot? When would you consider somebody for transplant?
That also becomes case by case. They have to be COVID negative. We require at least 2 swabs, consecutive swabs, to be COVID negative. We've had a bunch of referrals of patients who are still shedding COVID, but we would not transplant someone even if the concept was, well, they're just shedding, they're over the acute phase. I think all bets are off once you transplant folks. The key is to, the better shape you are going into a transplant, the better shape you will be coming out of a transplant. So we want patients to at least have some measure of mobility, to be a certain period of time out from the initial insult, and to have a CT where we deem that it's very unlikely that there's going to be reversibility. They've kind of been languishing on high flow oxygen for a while. And the sweet spot is to, and sometimes we'll have patients who've had a course and they've been down and out and they're very weak and debilitated. We want to get them up and moving and walking about. And the patient we just transplanted early this morning was a patient who was on ambulatory ECMO post-COVID. So you do what you can, and you have to be very, very selective in who you choose. We always go out of our way for patients who are younger. Much like we've had to kind of practice triage medicine in certain areas of the country and certainly other parts of the world, not everyone who's had COVID, who has residual damage, is a candidate for transplant. They obviously need all the other factors that we look for in terms of psychosocial support, lack of comorbidities, etc. So we're still in the process of trying to define that sweet spot, but it really becomes on a case-by-case basis.
All right. I don't think there are any more questions here. All right. I think that's been a great presentation, Dr. Nathan. Very, very informative and very interesting. Looking forward to hearing more about this. It's still an ongoing subject of research and lots more to be learned, certainly.
I agree. Yeah, more to follow. Hopefully we'll be in a much better place in a year's time. So thanks again for the opportunity, and thanks for joining us at your lunch hour today.
All right. Thank you very much.
Okay, bye-bye now.